Good afternoon and welcome. My name is Sue Prentice, and I'm the Executive Director of the American Trauma Society. It is my honor and my pleasure to partner with Pulsera today in the preparation and the delivery of our webinar, The Evolution of S-Trauma, using innovation and technology to improve trauma and stroke patient care. Again, we're pleased to have the opportunity to partner with our friends at Pulsera for this webinar today. First, I want to introduce, well, before I introduce our speakers, I just want to go over the rules of the road for webinars. As participants, you all come on and mute, and we're going to be able to, we'll keep you in mute until we have our question and answer session, which is the last part of the webinar. So it's usually the last 20 to 15 minutes. If you have a question at any point during the presentation, you can raise your hand. You'll see an icon for raising your hand or like a little pen to write a question. Go ahead and do that. I'll continue to monitor them, triage them, and we'll take care and we'll moderate this at the end. Also, although we've opened this up to anyone in the trauma world that's going to join us, if you want to watch or get a copy of the presentation, you have to be a member of the American Trauma Society. It'll be archived with our archived webinars on our website, again, for ATS members. So muted, questions and answers at the end, archived, which includes a copy of the slides. All right, so without further ado, I'm going to introduce briefly our two speakers today. We're so fortunate to have with us, and even from different parts of the country. That's what's great about webinars. So first presenting today, they're presenting as a team, but first up, it's going to be Heather Finch. Heather has her master's in nursing. She's an RN. She's a certified emergency nurse, and she's a TCRN. She's the manager of trauma services at UCHealth Memorial Hospital Central. Heather, which is a level 1 ACS verified trauma center in Colorado Springs, Colorado. She has over 20 years of clinical and leadership experience with an emphasis in nursing, behavioral health, and trauma. Heather is a leader and a positive change maker within her organization and the healthcare industry as a whole. Partnering with Heather today is Kate Leatherby. We're so pleased to have Kate with us as well. She is the Regional Vice President of West for Pulsera. With Kate's experience as both a paramedic and a pre-hospital care coordinator, as well as having a master's in public policy and management, Kate brings over 2 decades of unmatched clinical leadership experience as a regional vice president West for Pulsera. Today, again, working in her role, she leverages her clinical background to help EMS and hospital systems improve team communication, work through difficult processes of change management, and improve the lives of both patients and caregivers. As many of you probably just heard, my dog Maisie's excited to hear from Heather and Kate as well today. So I'm going to be turning this over and starting off with Heather.
Thank you so much, Sue. We appreciate the opportunity for us to be able to share our story and the development of our Strauma Alert system. We think it's pretty exciting, and we have learned a lot and are excited to share it with you. We have no financial conflicts of interest to disclose. I am not being paid by Pulsera to attend and present with you today. So our objectives for today are pretty simple. I want to review our Strauma Alert development, how this came about, and what we did to improve the process. We'll talk about our Strauma Alert outcomes. We're going to go over how we incorporated technology to improve the process and create better efficiencies. And lastly, we'll highlight some current state where we're at right now in today's world. So a little bit of background, as Sue mentioned, I am the trauma program manager at UCHealth Memorial in Colorado Springs. We are an ACS verified trauma center, When we developed this, we're seeing about 2,300 trauma admits per year. We're also a comprehensive stroke center, so I really want to acknowledge my stroke colleagues as they were very integral to the development of the Strauma Alert. This came about, the Strauma came about with some index cases in 2017. On a trauma end, we had some patients that came in, we recognized that they came in as a stroke alert, and it wasn't until later in their course that it was recognized that there may have been a traumatic mechanism. Injuries were then identified, and we felt like we could do better with that, as well as from our stroke partners. They were recognizing, not unlike other trauma centers in the United States, we have a huge population that are geriatric or geriatric ground level falls or found down patients. So they would come in, go through a trauma activation workup, and somewhere in the course it would be noted, hey, there's neurodeficits, we need to consult with stroke. And so there was delays on that end with them meeting their time parameters for best practice care and intervention. So back in 2017, this is just a really small meeting, pretty informal. Sat down with neurosurgery, neurocritical care intensivist, and our trauma medical director and said, what can we do? Back then, it was truly just about communication. How can we get stroke involved sooner? How can we get trauma and stroke together? And so there was just basic education at both committees just to say, hey, if you have a patient that has a high suspicion of this, please activate early. In addition, this work group of physicians was focused mostly on improving our order set. Our trauma order panel in our electronic health record needed to include the CT perfusion studies. And so that's where the term Strauma came from, was truly just a couple little orders for BCVI and brain perfusion studies. And so that's what we worked with for 2017 into 2018, pretty simple. What we're going to focus on now is the work that we did from 2019 to present. And the methods that we're going to go over are the development of our multidisciplinary work group, what the Strauma activation, what it was, what it does, as well as I'll show you our clinical practice, really algorithms. And then we will talk about data collection. Lastly, we'll quickly highlight on some training we did, really using our simulation techniques. So our work group was made up primarily of trauma, the trauma service line, our leaders, our trauma medical director, myself. We had our stroke service line leaders, neurologists. We had our ED partners, a physician champion, and we also would pull in other people ad hoc, for example, our radiologists. When this work group came together, it was really important for us to just better understand each other's service line and those quality metrics, what those best practice parameters and goals are for optimal patient outcomes. So it was sitting down to say, hey, this is what trauma's gold standard for time to CT is. This is what stroke standard is for that program. We also talked about other outcome measures like door to alteplase times, things like that. In addition, it was really important to discuss priorities with management and criteria for each other's activations. Our stroke partners were really interested in seeking information regarding why do you have to do this full assessment? Why can we not fast track CT first? What are you looking at for this? Can we bypass a fast exam, for example? And so there was a really good discussion to help them understand what those ATLS principles are and what the priorities are in the ambulance bay, in the recess bay. In addition, there was a conversation about who takes lead in these patients in that recess bay. Does trauma come first, trauma priority, making sure that we knew who was the team lead in these scenarios and how can we better incorporate our neurologists for the work that they need to do. It was agreed that, of course, indeed, trauma does need to be priority. You need to rule out those injuries and any bleeding so that they could either be cleared for intervention or move on if there are trauma needs, injuries to be managed. And I think most importantly was the decision and the commitment to work together. Both teams really did partner and had to remain committed over the next couple of years in order for this to be successful and to adapt and change. So the goal of this work group was really, and it remains true today, we want to improve patient outcomes by early recognition of both stroke and trauma injured patients by simultaneously activating and collaborating with trauma and stroke physicians. Okay, so then we'll fast forward here. The next meeting was saying, where are we at now? How is this process from 2017 working? We did education. We told everybody, please activate people simultaneously, both service lines, both stroke alert and trauma activation when you think it's appropriate. How are we doing? Our stroke partners at the table said, you know, we don't feel like we're getting involved early enough. We're still noticing on our patients some delays when they're a combined patient alert. We're still not getting there fast enough. And sure enough, when we looked at our data from the previous year, the time of arrival to stroke activation was about 16 minutes on average for those shared patients, which was obviously too long. We also had questions. This work group came together to say, hey, there's inconsistencies regarding what imaging and diagnostic practices there are. It varies slightly between provider to provider, and what is going to be, can we agree on workflow process? Lastly, this work group was focused on how can we improve training. Clearly, just sending it out in a general huddle tool or announcing at a committee meeting, we could do better to really focus on how to get these two dynamics to work better in the recess bay. We also, at this time of development, had telestroke support at night. And so that was another factor that was coming into play where, you know, you'd have a neurologist on site, but what happens when you had to go ahead and loop in the Telestroke provider and then work with that technology as well? So that's when the formal Strauma process was developed. So Strauma Alert, as we've mentioned, was really developed to allow for that simultaneous notification and response of the ED, stroke, and trauma teams. Our metrics that we decided to focus on initially were door to diagnosis, which is imperative and important for both teams, door to CT time, and then our stroke partners wanted to closely monitor the door to alteplase as well as the door to groin puncture times. All right, so this team worked together. They felt like we needed a tool just to be able to share with our providers and have everybody on the same page. This was our first version back in 2019. Very, very simple. As you can see, it just says a full trauma and a stroke alert are activated. What our messaging was to staff at the time is if you have suspicion of injury and you have a patient that has neurodeficits, that's pretty much like how it was described. Go ahead and you're going to bump that patient up to that full trauma activation so you can get the surgeon at the bedside and activate the stroke alert together. So we just reinforced that, and we reinforced the teaching, and the purpose is that we need that surgeon there to be able to clear that patient of injury. We did break it down into a hemodynamically stable patient arm and unstable patient arm. With the stable patients, it truly was about facilitating the patient to get to CT within 20 minutes of arrival. So it's doing your primary assessment, getting that access, labs, your basics, getting the portable chest x-ray, and then if appropriate, moving on to CT so that those patients could be identified for intervention. Whereas on the unstable patient end, we highlighted again those ATLS guidelines to include there might be delays because your patient needs to be resuscitated. You have to do the secondary. This is where the collaboration on both arms, we really did specify during the disability assessment, that's when you're collaborating, the surgeon's collaborating with the neurologist, and the neurologist is allowed some time to do a neuro assessment for the NIH stroke scale. Then it goes on to, for those hemodynamically unstable patients, they need to also have that pelvic x-ray and FAST exam to assess for bleeding. And then at the end of that, that's when the trauma surgeon and neurologist would confer and review the next plan of care steps. The other thing that we did at this time, now that we had both teams, both physician leaders, they had collaborated, they were in agreement regarding workflow process, was to educate. And we already had a very established simulation trauma activation training program. We go monthly to our ED and practice scenarios. And so that was very well established. What was unique for this situation is our stroke partners, the neurologists, were very interested in seeing how those traumas are run and being part of it. And really, this was an opportunity for both teams to see how does this play out in that scenario. This is obviously a really old picture, but just to highlight for you, what we did was we had a scenario that was developed around a stable patient arm so that the neurologists could really see how that works, spend that time on the NIH assessment, practice with what that would look like, traveling to CT and having that collaboration. We had another scenario that followed the unstable patient arm, which was really beneficial for our partners all to see what happens during that phase with a patient and why we just can't jump to CT in those cases. And then lastly, we also incorporated a scenario that had a telestroke component. So it definitely was novel to have our physician on a stick being able to play around with where to post him, how the primary nurse might assist him with completing the NIH assessment, so on and so forth. And that was really successful. So the question that comes up is, did this make a difference? Was this improving? We had done all this education, we rolled out our algorithm. Were we doing any better? And the answer to that is yes, indeed we were. So we appreciated a 35% decrease in time to CT from 31 minutes to 20. This is comparing our 2019 data to our 2017 data. We did not include 2018 since there was an informal process, a lot of education. We also improved our door to alteplase times from 47 minutes to 40 minutes, which was 14% improvement, and our door to groin puncture times improved by 24% down to 61 minutes. At this point, before Kate takes over, we really had an opportunity. While we felt like this was working well for us, we knew that our cardiac and our stroke partners had used another platform that really allowed, instead of just paging technologies through our alarm dispatch center or hospital operator, they were also leveraging another platform that allowed for better team communication and not so siloed one way. So that's where we reached out to Kate to talk about trauma activations and Strauma activations and how they could help us.
Okay. Great. Thank you so much, Heather. Big thanks to all of you on this webinar for taking time out of your day to spend with us here, and to Sue and the ATS for the opportunity to talk about the role that Pulsera has played in this incredible initiative. So over the next few slides, I'm going to provide you with an introduction as to what Pulsera is, some context surrounding the Pulsera initiative in the Colorado Springs region, and how our solution was able to facilitate the communication needs related to creating the Strauma activation. So first, I want to answer for you, what is Pulsera? Well, we're a mobile-first, cloud-based communication and logistics platform that connects teams across organizations to create systems of care that scale. And what I mean by systems of care that scale is with Pulsera, you have one single solution that you can use to communicate about all patients coming into your facility via all methods of arrival. So Pulsera isn't just limited to the EMS patient, a transfer patient, or the walk-in patient. You can create a patient channel for even inpatients that have been admitted to a floor and may experience a condition that requires immediate activation of care team members. So all patients, all methods of arrival. So the trauma patient coming into your facility with time critical diagnosis via EMS, the stroke patient on the ortho floor, or you can scale up the platform to meet communication needs during an event like the pandemic, which we've all been dealing with for close to 2 years now, where the focus might be related to logistics of patient movement, load balancing, or even leveraging the platform for things like video consult to mitigate surge and preserve PPE. Okay. There we go. Okay, so we operate primarily in 3 spaces. We operate in the pre-hospital, the intra-facility, and the inter-facility spaces. That's something very unique about Pulsera. Some other solutions that you may be familiar with operate in 1, sometimes 2 of those spaces, but we're really the only mobile communication platform to cover all 3. And as healthcare providers, we all know that the patient's journey just doesn't start with EMS in the pre-hospital space and end at the doors of the ED. So depending on the patient diagnosis, you may have the need to activate multiple care team members at different places in your facility. Maybe you have people on call teams that are at home, so these care team members can be distributed. There may be patients that need to be moved from an outlying facility into your organization for definitive care. So I think this slide really illustrates the vast number of people that may be needed or involved in communicating and coordinating care for a single patient event. So when Heather and her team approached me in 2020 to discuss the role that Pulsera could play in the Strauma activation, the hospitals and EMS agencies in the Colorado Springs region had been using Pulsera for stroke and SEMI notification since 2016, as Heather touched on. And then later on, they started using Pulsera for general patient notifications for those patients that did not fall within a time-sensitive module. Also at that time, UCHealth had very recently implemented alerting through Pulsera for their trauma activation. So hence it seemed pretty logical at that time that the Strauma activation would be built into Pulsera for dual notification to the trauma and stroke teams. Okay, so let's look at the problem via different visualization here. I want you all to think of how traditionally we communicate in healthcare. So we're pretty good at communicating with each other in our daily lives through apps, video conference calls, etc. But then we step into the healthcare space and we're often communicating in silos, which, excuse me, is truly a barrier to creating that shared consciousness amongst all care team members. And an example I often use here to help with that visualization is if some of you remember the game of telephone that you may have played as a child. No matter how hard you try to preserve the integrity of the information you receive from the person next to you, information always ends up being lost or transformed by the time it reaches the final person in the chain. And it's really no different when we communicate in silos in healthcare. So what Pulsera has done is we've enabled greater transparency amongst care team members by having all pertinent information at the tip of our fingers, where we can communicate in one unified patient channel, which we can't do when we're utilizing fragmented technology like faxes, radios, and pagers. Okay, so on this slide here, I'm going to show you side-by-side comparison of the Strauma Alert pre-Pulsera and then post-Pulsera. So pre-Pulsera, they would have the pre-hospital patch would come into the emergency department to the charge nurse. The charge nurse would then determine the trauma activation level. The charge nurse would then provide the information to the unit clerk, who would call star 811 to connect with the ADC operator. The ADC operator would then send out a page to the appropriate people from the stroke team. They would then have to send out another page to the trauma team members, and then make a separate call to the trauma surgeons. And then the ADC, while all of this is going on, is also receiving responses back from those team members that had been paged. So Heather and her team looked at this process, the number of phone calls and pages involved, and said, hey, Kate, we recently started using this for trauma and it's been great. Can we eliminate some of these steps in an effort to save time by utilizing Pulsera? What can we do here? So I'm going to show you the second graph here. And by incorporating Pulsera into the process, they were able to eliminate a whole lot of steps. So went down from about 7 steps to 2. And so the process, and once it was refined and built into Pulsera, it unfolded very much the same way with the pre-hospital notification to the ED charge nurse via Pulsera. And then the ED charge nurse would look at clinically significant information in the patient channel. So that's something I really want to highlight there. Clinically significant information, they would determine the level of activation, and then they would activate both the stroke and trauma teams directly from the patient channel without having to make any phone calls. So the result being all care team members are able to communicate in a dedicated patient channel with the option to use both synchronous and asynchronous communication. And you can really see that that once 7-step process has now become a 2-step process. We've eliminated a bunch of phone calls and pages, and care team members are receiving, like I said, clinically significant data versus alphanumeric page with limited information about the patient. The other thing that's great about Pulsera is the charge nurse has access to see who has received the notification without any additional phone calls having to take place to say, yes, the members of the trauma team are responding and the stroke team have received that notification. They can see that right in the patient channel, again, without having to make any additional phone calls. So here, in lieu of a live demonstration, I have a little animation here to help you all kind of wrap your mind around what was just discussed in a visual of what it looks like to receive a notification in Pulsera. So our EMS partners would enter information into Pulsera. They can utilize things like the camera to take photographs, maybe of an accident scene. And again, we're cloud-based, nothing is stored on the native device. They can communicate synchronously if they have to. Sometimes you just need to connect with somebody and make a phone call. But there's a lot of features within the app that allows you to communicate that clinically significant data. So our EMS partners have entered in, they're gonna hit alert, that big alert button at the bottom. That's gonna send all of the information. You can see the charge nurse gets a notification there. There's a banner across the top of the screen. There's also an audible alert that comes along with that as well. So now you can see that that button at the bottom has changed from alert to activate. So EMS hit alert. This is the charge nurse looking at the screen now, and they've looked at all of the information. They can determine the level of activation, and they just hit activate at the bottom of the screen. And so that's going to go to all of the members of the care team that need to be involved. So the stroke and trauma teams. The other thing that they're doing at UCHealth is their EMS partners are really trying to make an effort to get driver's license into the patient channel. So they're also pre-registering those patients to create some additional time savings there. Okay, I'm gonna hand it back over to you, Heather, to talk about some results.
Thanks, Kate. Really appreciate it. Before I go into this slide, I just want to highlight, it's interesting, back on one of Kate's slides, she talks about having a separate call to the trauma surgeons after we had our pages go out. And that's because it just wasn't working. It wasn't timely. There was almost a delay or a rolling list of priorities with those pages. And so there wasn't a lot of faith that there would be real-time communication that would allow our surgeons to get to the bedside quickly. And so that's why we had a separate, they would call directly to the surgeon's cell phone just to make sure they received the page and knew the patient was coming. And oftentimes those calls were beating the page. So now focus on us. We've implemented it. We wanted to see, is it making a difference? So we did compare our first 6 months of utilization, and we compared that to our 2019 data. And sure enough, we did see an improvement. 73% average response to bedside for our trauma surgeons went from almost 8 minutes down to just a smidge over 2 minutes. So that's 73% improvement. Then our door to CT times for our patients went from about 22 minutes down to just about 13.5 minutes. So an additional 39% improvement. So for us, it did verify anecdotally. We felt it. We still had hybrid. We had people that also received our paging system as well as had this application and would receive these notifications. We did initially, our surgeon group wanted to have a backup. We wanted to do dual process for at least a couple weeks just to verify that there weren't any problems. And sure enough, your results are right there. They were getting the results. The whole team was communicating. What was novel about this is that we incorporated 2 service lines, so everybody was on the same page. You could make sure that both groups had received the information for the patient. All right. So this work group felt good about that, and we also worked to discuss monitoring. What did we want to look at together and meet about and report out to each other at our work group meetings? And we created a dashboard. Certainly each service line continued to monitor more detailed information, but for this one we looked at our time to CT. We were tracking activation compliance, and we're happy to see at least a 93%, about an average of 93% compliance at this time overall. Admissions, trauma versus stroke. We wanted to know how many of our patients were admitted with traumatic injuries or stroke injuries, or was this just a null activation? And really what we found was about 21% of our Straumas did have traumatic injury. About another 40% had primary stroke admission diagnosis. And then the other, let me see about that, that was about 30% left over, was for things like sepsis, metabolic derangement, respiratory distress. So that's kind of how it broke down. In addition, we looked at our ISS from our injury severity score from a trauma standpoint, as well as which regions these patients, where were they injured? And we found that that was primarily head and chest. Then our neuro partners were absolutely looking at what type of admission it was for them. Was this an intracerebral bleed? Was this a CVA, etc.? Lastly, this group, in addition to monitoring, we would meet and we would bring forth any cases that we thought there was potential OFI that we wanted to have these physician leaders co-case review so that we could incorporate that into our PIPS process. So with this, we looked at data and we recognized that we needed to report out to our stakeholders. There was some feedback, especially from our ED partners and from some of the surgeons, to say, hey, we think we're overshooting. We need to, we feel like we're overcalling it. Anybody who's found down, does that really necessitate us calling a Strauma activation, having a full trauma response, or is there anything we can do to really look to see how we're activating, and is there a way to improve this? We were worried about resources, just like you would do with any your trauma activation criteria that you review at least annually. So what we did is we pulled a cohort, we looked at our found down patients and our Strauma activations, and we looked at did people have suspicion of trauma or did they have signs of trauma? And to make a long story short, our data did show that there was very, very low yield of traumatic injury for patients that just had suspicion without signs of trauma. And just to be clear, what we're defining as signs of trauma, that could be contusions, abrasions, lacerations. We included pain and tenderness, swelling. So there's a list. It's pretty hard to read on this little document, but that's pretty much what that included. And so with that, we met again together to say, hey, we think we can narrow down this population further. And that's when we developed our updated algorithm that did two things. It further defined the stroke activation criteria for the LVO candidates, etc. And then we defined the signs of trauma, because as our ED charge nurses, they were, they're the ones that are taking those patches, having to make a lot of these calls sometimes. It was important to give them tools to be able to do their job and do it well. And so we incorporated those. We also defined a time parameter for those stroke patients, so they had to be within 24 hours of onset of symptoms. Again, we highlighted signs of trauma now, not just suspicion. So if it was found down with neurodeficits, unless they had, tenderness, pain, abrasions, head lag, something like that, that's what would create the Strauma activation. We then transposed the stable patient and unstable patient arms to focus first on those unstable patients. The middle 3 sections, the meat of it is essentially the same, except for we added in a little bit more detail and included the notation that the neurologist is going to complete the NIH stroke scale during the disability exam. And then we, at the very end, we talked about disposition and admitting service for these patients. Then we looked at our data to see first quarter 2021, did that improve? Were we making any difference to some of our outcomes? And we did see additional improvement with our door to CT times by 35% down to 13 minutes. Door to alteplase improved by about 5 minutes down to 35. And our door to groin puncture was really too small. We had a very low N for that time frame. That was only 3 months, an N of, I think, 4. So where are we at today? We feel like we've come a long way with our Strauma development. We've had enough time to start looking at data and feel like this is worthwhile. I know my trauma medical directors, they've recently done an analysis, and truly the data shows that this is safe, that there is benefit, and it improves the care for our patients, period. So whether that's for stroke outcomes or for trauma assessment intervention, that communication and collaboration is helping our patients. Our next steps right now are expanding that communication pathway. So we still are OR partners. We have just outfitted our charge nurses and our anesthesia folks with the Pulsera platform so that they too can get this real-time notification much sooner, so that they can be notified in advance if there's potentially a patient who needs intervention, or they're activated when they're needed, especially by the stroke team. And then I'm going to turn it over to Kate, because next step is it's really about regionalization and how we can apply this as a true trauma system in our community.
Yeah, thanks again, Heather. So for transfers, the rural and critical access hospitals, speaking of regionalization, the Colorado Springs region did come onto the Pulsera platform together in a community partnership with competing health systems. So they're working on the rural and critical access hospitals to incorporate them into the Pulsera via transfer workflow. So thinking back to what I said on a previous slide, all patients, all methods of arrival, including transfer. So spoke to Hub, enabling really that shared consciousness around patient care during that transfer care journey as well. So again, clinically significant data, maintaining the integrity of that data in one dedicated patient channel. And an early benefit that's being realized by incorporating Pulsera into that transfer workflow is patient door out of time from spoke facility. They're noticing anecdotally, not really a lot of formal data, but again, anecdotally, 15 to 20 minutes, they're getting those patients moved more quickly out of those facilities into definitive care at Memorial Hospital Central down in the Springs. And so that's actually the end of our presentation, and we're going to move on to question and answer portion of the meeting here. And so thank you all, and we're excited to answer some of your questions.
Great, Heather and Kate, great job, thank you. I'm going to pull up. So I have a few questions here for you, so hang on just a second. First, I'm going to go to raised hands. I see a Sarah, maybe Monshare. So Sarah, I'm going to put your hand down and I'm going to unmute you if you'd like to ask your question. Sarah, you're unmuted. All right. Her hand is still up. All right, I'm going to mute Sarah again. Maybe she wrote her question in. Check. Okay. Mute Sarah. Very good. Okay, I have a question here from Christine. It says, is your center a verified stroke center? This must be for Heather. And does your stroke program have a goal of door to result of 25 minutes?
I believe so. I would really have to check again with the stroke coordinator, but yes, we are a verified comprehensive stroke center of excellence. So yes, they are constantly modifying those patient outcome numbers with the best practice numbers.
Okay, great. Thank you, Heather. And I have a question for Kate. It is from Christian. And Christian's question is, towards the very end, you talked about regionalization of programs through health systems and maybe competing health systems. How were you able to achieve that? What were some of the successors as well as some of the barriers you may have encountered?
Yeah,
Yes.
that's. Do you want to speak to that, Kate? Go for it.
Yeah,
Both of you, both of you can
maybe we can both speak to it. I don't look at it as my success. They have very, very strong leadership from all of the different organizations within the Colorado Springs region. I believe we have somewhere around 20 EMS agencies that participate in the Pulsera initiative. And what's interesting is back in May, they actually went to all patient notifications through Pulsera. So they still have the radio as a backup, but that is their primary method of notification to all of the hospitals in the region. Heather probably has a little bit more historical information because it started in 2016. I didn't start with Pulsera until 2018. So Heather can maybe speak to actually how everybody came together.
I think in full transparency, it didn't happen overnight. It was quite a process. And, it started small and focused with those alerts. I think that was part of the success is with those alerts that were, you either meet the criteria or you don't, it really started working. Where we came into some challenge with trauma is you're not just a trauma or not. You can be a partial activation, you can be a full activation, and what are those criteria? It's much more complicated. And so there was a lot of discussion. We had, in our ReTAC, a lot of support, our trauma leadership. Ultimately, with our competing systems, the end goal is patient outcomes and care. Like, you have to think of why you're doing it. Is there a benefit to being able to communicate well? We've all had those challenges with patch systems, radio systems, where you're trying to communicate maybe two ways. Your ED staff is just overburdened with trying to prepare your room, get calls out. And as you could see, we had multiple steps. I mean, it took 7 steps just for the Strauma. You could knock out one of those for a regular alert. So I think it was a lot of communication. For the community part, there was a lot of community meetings that our partners were part of. And we, in all fairness, explored other systems too, just to see what would work best for us. So a lot of effort and really from leadership everywhere.
Yeah, and I'll add on to that just a little bit. You asked about perceived barriers. I think the biggest barrier to a community initiative like that is, and any time you're implementing change, is the change management process. We have a saying at Pulsera, it's 5% technology, 15% process, 80% people. And the change management process and really engaging all of the stakeholders that are going to be involved, allowing them to see what is this new technology, because it is a paradigm shift when you're changing from radio and phone method of notification to new technology. So at Pulsera, we really try to work with our partners to help them with that change management process. And as Heather talked about, the ReTAC facilitated some community work groups and communication committee bi-monthly. So we really stayed in close contact with each other, and I tried to stay very much aligned on what the goals of the community were.
I do want to give a quick shout out. I think for integration of Pulsera or whatever platform people are using, you have to have buy-in from your ED. We would not have been successful. A lot of that work of development and implementation and troubleshooting falls with those ED partners. And so I do want to recognize my ED nurse liaison for all the work she did to make that successful. And our culture is just to embrace and move forward, fail fast. So that's what we did. But we succeeded instead.
Thanks, Heather and Kate. And although I have other questions to ask you, my question I was going to ask you already have answered, which is what was central to the buy-in and implementation. And I really feel like I've heard you talk about that already. So let's see. We have a question from Darcy, and it says, can you just, and I think this might be for you, Heather, can you describe how this would work at a facility with no neurology, neurosurgery coverage, but tele-neuro only? I think that could be for either one of you. So,
Yeah. So that's interesting. So we did at the very beginning have that telestroke component, and it does add a different dynamic. So I think it can work. It's a matter of how do you activate that telestroke person. And so in this case, I don't know what size facility you're referring to, you know, how many people you would have on staff, but I believe if I go back to the recesses of my mind, how that worked for us with telestroke is we would notify the whole stroke page group, and with the Pulsera platform in particular, people put themselves on and off call. So if you were the stroke provider covering, whether it was telestroke, whatever, you would put yourself on call. That would notify you. And then we did have assigned roles in the ED of who the person was. Generally, that was our assigned trauma nurse that would be responsible for activating our physician on a stick, calling in and connecting with the telestroke physician so that he could be part of that. So you can still do it because people have control and they put themselves on and off call. So it's just working with those partners.
And from the Pulsera side, there is the ability I talked about, synchronous and asynchronous communication. So you do have the ability within the Pulsera platform to connect via live video. You also have the ability to add multi-parties into that video conversation. So you do have the ability to connect and to consult in that way.
Okay. Great, thank you both. This is great tag teaming from the both of you. So I have a question from Mackenzie. She asks, are there any areas where you didn't see improvement upon implementation, and how did you address those trouble spots?
Quite honestly, no, we did not. Well, I'll tell you, the last one that I showed you with the door to groin puncture time, that went up slightly, but that was an N of 4. So, and that's not our trauma measure. We really rely on our stroke partners to drill down, see what happened to those. And with COVID, I haven't met with them to go over that data this year, but overall, no, everything so far has shown an improvement, but we'll continue to monitor. Again, I need to run my 2021 data throughout the year, and if so, we, the work group, we still report out on it quarterly because we have this in place and because our trends are currently meeting our baseline. That works for us. As somebody mentioned earlier, is there new parameters, is there new guidelines or time parameters? We'll meet, adjust, and compare, and work with them to see if there's any improvements needed. With COVID, with all the new people coming on board, I'm sure we'll appreciate some opportunities next time we run some data.
Great. All right, I have a question from Caesar. Does the use of the Pulsera application help collect data specific to quality metrics of door to CT, door to needle, or door to groin puncture, all valuable data for stroke centers?
Yeah, I can take a shot at that one first. So everything you touch in the Pulsera platform becomes a data point on the back end. So we do capture quality metrics like door to CT, door to needle, all those types of things. So, and that data is then available to any, what we call somebody that has the role-based access of administrator to look at that data. Heather, I know that some of your folks are using that data on the back end for trauma, but we do collect those quality metrics for stroke and trauma. We are the only Get With The Guidelines vendor that's listed on the American Heart website for communication platform. So because we collect the data that you need for reporting those quality metrics.
Yeah, absolutely. Our stroke and cardiac partners are much more advanced right now than we are. It was quite the accomplishment to move to this platform, and we were just working out the kinks just to make sure that we were getting notifications and getting the basics down. For sure, the stroke coordinator has worked with Kate and her team, and they have a lot of quality metrics. It's pretty neat when you see these Strauma activations. You can see there's different things that connect that are more stroke related. Eventually, we may tie that in for our trauma, but my registry abstracts completely out of the electronic medical record for the most part. We do pull some reports from Pulsera, and then of course, Kate does share volume calls, things like that.
Yeah. And things like what you didn't really see in that animation there, CT, the folks in CT are being notified simultaneously as well. So they have Pulsera in CT, and then once CT is complete, they can toggle CT complete. Everybody on the channel gets the notification that CT or CTA has been completed. And then, like I said, we're capturing that on the back end. You can see what time that was toggled.
Right, that's great. All right, I have a question from Kathy. Did you have any interaction with your state trauma manager when implementing this communications platform?
We really didn't. We use another platform just to communicate regarding, bypass statuses, divert statuses. But as far as this, not that I was part of. That's a great question. I'd have to go back and look at notes, but I think he was certainly aware of it, but I don't recall meetings where they were present with our big community groups. Our ReTAC coordinator for sure is in communication as well, so maybe informally.
All right. So, and just for clarification, your ReTAC is your regional trauma
advisory council. Yeah, EMS and trauma advisory council.
Okay, great. All right, I have another question from Darcy. Ultimately, this seems like the initial notification depends on an accurate assessment by EMS. What happens if there is a poor assessment report and more info is discovered in the ED? And then the second part of that is, what is your process for improving EMS reports? So first is, if the report doesn't match what you actually see, what happens then in terms of activation?
Can I respond to that?
Yeah.
So where we are at with how we activate is, for sure, our EMS partners can activate from the field. But typically what they do is say, we have a trauma alert for you. We have concerns. We have a trauma patient for you. What we rely on is our charge nurses know our criteria. They know our different alert levels. We have more than just a full and a limited activation. We also have some other alerts, like a geriatric anticoagulated protocol, things like that. So our charge nurses are the ones that are responsible for making that final call of which level, unless EMS specifically says something. So most of that burden falls on the charge nurses, and it's not unlike getting patches the old-fashioned way. We worked with, in our community work groups, we had our EMS partners from the different agencies to include our fire presence, so that we could talk about, hey, how does this look and what is the bare minimum information we need from you? And truly, from a trauma perspective, we really just need to know some basic vital signs and a mechanism, and whether they're following commands or not. With stroke, they also need to know, they know what to report as far as those parameters. So it was actually a pretty smooth transition, and not unlike, and what's even better is they can include pictures of the scene. So if there was a MVC, or if it's just easier for them to give an audio report, there's a capability of doing that as well. Okay, is there anything you wanted to add?
No, I think you covered it. That was good.
Okay, and just wanted to make sure that so that was great. Completely covered the second part of the question, because I heard some of it. What's the process for improving EMS reports? So I think that's almost like a standalone question, but something we hear throughout the country. So
it's an ongoing report. I think our community, with the other system, we have worked as a regional, we have a regional committee that meets with both systems and EMS leadership. And we have talked about this several years, not more than several, probably 4 or 5 years ago. We met together to work to say, hey, can we standardize what we expect from an EMS report? And so we had some basics there. So we had already done work years ago to say these are core things that are important for us. Certainly with changing the platform and wanting to not put undue burden on our pre-hospital providers, we had to just decide, do we need all of this detail or can we function? What's the bare minimum that we need to function off of? And we talked about that and came to agreements ahead of time. When we have a fallout, part of our PIPS process or PI process here is we have an EMS liaison. We go to him and say, hey, this was lacking. There was a complete difference from what they said, or they called in a stroke, and there was a huge traumatic mechanism with signs of trauma. And so we will go through that PIPS process. He'll follow up. There'll be QA on it, whether it's direct education or not. But the expectation is you get a patch and you can call from a patch, but the minute the patient arrives on your primary assessment, if anything's different, the blood pressure tanks or anything like that, the expectation is our team here has every right to upgrade and call accordingly.
Okay.
The ability from the mobile app to change trauma level, as you discover more information, or even change the module if it starts as a general patient and you realize, oh, this patient has a bleed, we need to activate the stroke team. You have the ability to change from general patient to a time-sensitive module as well.
Thank you, Kate. That's important.
Great. We've got 3 more in just a couple of minutes, so we'll try to get through all of these. So, question from Paul is, what are the hardware requirements to the Pulsera platform?
So that's a great question. So we're cloud-based. It requires no on-site servers or anything like that. The only requirement would be a mobile device. So we operate on iOS and Android enabled mobile devices. So that can be an iPad, that can be an Android cell phone. We have call team members. I think it's, people get a little bit nervous about, I don't want to have this on my personal phone. But again, it's cloud-based, so nothing stored on the native device. You have to authenticate in the app to access patient information. So the only requirement is a device to communicate, a smartphone.
Okay, thank you. A question from Adam. In relation to IT security, does your staff utilize their own personal devices, or do you have unit/department specific devices? And do you all have a transfer center? And is this incorporated within that transfer center? So it's kind of sort of 2 questions. One is about transfer centers and the incorporation there. And the other is about where the devices that are used, are they personal or are they hospital based?
Great. Really great questions. Yes, we have a transfer center. It is not integrated with them yet. So this is strictly from pre-hospital or facility into us. So it would run parallel. So if it was from a facility, they would still use our transfer center and send this concurrently. As far as devices, for us, our ED, for example, it's a hospital device. They use an iPad. We've asked for a desktop application. So we're always in communication to see how that, how we can improve. So the iPad works very, very well. And that way we have a couple people. We have a charge nurse. We also have another backup nurse that helps to manage our calls, because now all of our calls essentially are coming in on Pulsera. But there's also our trauma docs or myself. I have that also on my personal cell phone.
Okay. And our last question of the day, and we'll be wrapping up, is, can Pulsera data/usage be geared towards EMS feedback? Well, it sounds like, can you take the data you get here that's EMS related and use it as part of the feedback that you provide?
Yeah. So something that's really cool, having been a paramedic and then having been on the pre-hospital side supplying feedback to people, we like to get feedback on our patients in as close to real time as possible. We want to know what the outcome was. So a really cool functionality within Pulsera is when you stop the case, it's going to provide some immediate feedback to those providers. We have docs or nurses that will maybe dictate a little note via audio clip into the patient channel to thank the providers and give them some additional feedback, or maybe dictate in the message functionality, dictate a message to provide them with feedback. So you do have the ability to provide feedback in as close to real time as possible, which is something that I've been on both ends and faced challenges with in a past life.
All right, Great. Well, Heather, Kate, this has been a great hour with you. I think we could certainly go on for a lot longer. I want to thank you both for taking the time to join us today, and the members not just of the American Trauma Society, but we opened this up. There's members from the different EMS associations and trauma associations in the country that have joined us, and we all appreciate your time on the ability to learn about this communications platform across, across the continuum, but how it helps to improve our structured systems of care. And on behalf of the American Trauma Society, not only do I want to thank you both, as I have, but thank Pulsera for the partnership and the opportunity to talk about this and its unique implications. So thank you, everybody. Don't forget, if you're a member of the American Trauma Society and you want to watch this, it will be archived. It usually takes about a week before you can find it in your archived webinars. And so have at it. The slides will be there. And for those of you who aren't members, please visit www.amtrauma.org. And we'd certainly love to have you on board our team here at the American Trauma Society. Again, Heather, Kate, and even Nathan, great to work with you all. See you later.
Thank you so much. Have a great day, everybody.
Bye.